Hey there, it's Marvin Music with MedicareSchool.com, and we want to welcome you to this edition of Medicare Monday. Every Monday, I like to dive into a topic that I think will be helpful for you. We have over 20 agents in our firm, and we write probably about 1,000 plans every month for people all over the country. So we encounter really about every situation and really have seen about every situation that you may ever come across in Medicare. So that's really the purpose of Medicare Monday, to pick a topic that I know is essential for you to know. We try to cut through all the fluff and really get to really those essential things that I think you need to know about Medicare. And as always, I just want to begin by asking a question to kind of really set the stage, and that's this. Two of them, really. One, do you have to know everything about Medicare in order to make great Medicare decisions? And the answer to that question is no, you don't. You do not have to be an expert to make good Medicare decisions. However, do you have to know some things about Medicare in order to make good Medicare decisions? And that answer is absolutely yes, you do. So many times people make impulsive decisions. They make decisions based upon what their neighbor did or their coworker did or maybe their friend did. And you don't want to copy someone, folks. You want to do what is really best for your situation. Sometimes people get advice from agents that are rookies or just chasing commissions and will really not be thorough in explaining all the options that people have available to them. And sometimes people act just upon bad advice. They get advice from someone who really doesn't understand Medicare well, cannot connect all the dots, and when they act upon bad advice, it can cost them dearly. And so we're aware of those kind of situations. We also know there's a lot of ads today that you'll see on TV, on the internet, certainly in the mail. And those ads only give you part of the story. They usually don't give you all the story. With every plan, there's pros and there's cons. And so again, that's what we want to cover during our Medicare Mondays. And so if you're new to this, we hope that you'll enjoy this session, but also tell your friends about it. And then every Monday, again, we'll get into the nuts and bolts of Medicare. So my topic this evening is really all about the changes that are going to come about as a result of the Inflation Reduction Act that was just passed last week. And again, there's several things in that legislation that you and I may not agree with and even be in favor of, but that's really not the point. The point is that has become law, whether I like it or not. But what I do know is that it has had some impact upon our business, which is the health insurance business. First off, those people that are on Affordable Care Act plans. In other words, they went through the healthcare exchange to be able to get their individual plans. Those plans, almost always, people on those plans receive a subsidy. Now, again, not always, but usually. So you could have a $1,000 premium on an ACA plan, and you're getting a subsidy of maybe $700, $800, $900. And so those subsidies are going to be extended through 2025. So what they basically did is they kept that program alive for another 3 years. And then also there were several things that were affected as it relates to Medicare Part D plans. D plans are drug plans, and so there's several things that are going to happen. We'll see changes that will occur in 2023, 24, 25, 26. So some of these changes are going to be spread out over a period of time, and they're important. And so I'm going to talk about all of those changes as it relates to Part D plans. But I also told you in this that we're going to talk about what things were not changed. And so I actually just want to simply do a review of the 4 parts of Medicare before I get into how the Inflation Reduction Act has impacted Part D plans. If you're new to Medicare, you have been reading about Medicare, you saw that there's actually 4 parts to Medicare. Those parts are parts A, B, C, and D. And so what I want to do is I want to take those 4 parts and really talk about the details of each of those parts. And so we're going to talk about the eligibility, we're going to talk about enrollment into those parts of Medicare, the coverage or the essential aspects of having coverage under those 4 parts of Medicare, and then the expenses that are involved, and then what kind of experience are you going to have in order to, when you get on those parts, what does that look like whenever you are using that form of Medicare coverage? Okay, so that's kind of my outline tonight as we look at the 4 parts of Medicare, and then again I'll conclude with those different changes that are impacted on Part D plans because of the recent legislation. All right, so let's talk first of all about Medicare Part A. Part A we refer to as original Medicare Part A, and it is basically the inpatient side of Medicare. So when someone's in the hospital, it's Part A, and the Part A system that's going to pay the bills. It's also when someone goes to a skilled nursing facility because of maybe a stroke or a hip replacement or an injury or an accident or a fall. They're going to skilled nursing for inpatient, fairly extensive rehab. And it is the A of Medicare that's going to pay those expenses. So that's what A is all about. It's inpatient for hospital and inpatient, as well as skilled nursing facilities. Now the B side of Medicare, again, original Medicare B, is the outpatient side of Medicare. The outpatient side is going to be for doctor services, durable medical equipment, any outpatient surgery, maybe labs or tests or MRIs or CAT scans, cataract surgery. So anything on an outpatient basis, as well as, folks, all doctor-related services. Whenever you're seeing a doctor in their office, or maybe that doctor is coming to see you in the hospital, it is the B of Medicare that always pays the doctors. Now, A pays the facility, the hospital and skilled nursing expenses, but B is going to pay the doctors that take care of you in those facilities. It could be a specialist. It could be an ER doc, emergency room doc. It could be a hospitalist that makes the rounds. It could be a surgeon, an anesthesiologist, but all the doctors are paid through the B of Medicare, whether it's inpatient or outpatient. That takes us then to C plans. C plans are called replacement plans. They are called Advantage plans. The Advantage plans came into existence now 18, 19 years ago, back in 2003. And they are accurately called replacement plans, because what happens is when someone chooses to enroll into an Advantage plan, they're replacing, they meaning the insurance company, the private health insurance company, is replacing Medicare A and B on your behalf. So either you stay in original Medicare A and B in an outpatient, or you get a replacement plan called the C plan that's going to take care of you both in and outpatient. And those are your two options when you go on Medicare. And then when it comes to Part D plans, Part D plans are for drug plans. Now, drug plans that are Part D are for self-administered medications, because original Medicare A and B will cover medications that are professionally administered. Those meds that you need in the hospital, or those meds that you need on an outpatient basis, A and B is going to pay for those, as well as the C plan. But drug plans are for self-administered medications. And so whenever we have a drug plan, when we've made the choice to stay in original Medicare A and B and get a supplemental plan, then your drug plan is separate. It's called a standalone drug plan. It has a separate policy, has a separate premium. And again, these are the meds that you're going to take on your own: high blood pressure, cholesterol medications, maybe your diabetes medications. Those things are paid through a standalone drug plan. When you decide to get an Advantage plan, which is the C plan, they actually add a drug plan to that. And that's why we call them MAPDs, Medicare Advantage with prescription drug, which means that private health insurance company that's replaced Medicare for you will embed or include a prescription drug plan as part of that package. Okay, so those are the four parts of Medicare, and that's the eligibility for those plans, A, B, C, and D, and those are the kinds of things that they're going to cover. Now, let's talk about eligibility for Medicare. In order to be eligible for Medicare Parts A and Part B, you have to have 40 quarters paid into the Medicare tax system. Now, if you're presently working for someone, right now 1.45% of every dollar that you make is going into Medicare, and your employer matches that. The employer match comes in, funds Medicare as well as Medicaid. If you're working right now for someone, you're paying 6.20% for Social Security, and your employer matches that. We call these FICA taxes. And so the point is, all of us are funding Medicare and Social Security. And in order to be eligible to draw benefits off of those at whatever time we decide to draw, we have to have at least 40 quarters paid in, which is basically 10 years worth of work. So anyone that has 10 years worth of work, 40 quarters paid into the system, is eligible for Medicare A and B. Now, there are some times when people don't have 40 quarters, so what we do is we try to find those from someone else's work record. That someone else is called a qualifying spouse. And this could be someone you're married to presently, or someone you were married to and they died, or maybe someone that you're married to and now you're divorced. And there's certain rules for us to be able to draw benefits from someone else's work record. But if it's someone that you were married to, you no longer are, and that person is still alive and you all divorced, you had to have been married to that person for 10 years or longer, and you couldn't remarry prior to the age of 60. If you remarry prior to the age of 60, you cannot draw from that ex-spouse. But as long as the marriage lasted 10 years and you did not remarry prior to the age of 60, you can draw from that ex-spouse. If your spouse died while you're married, as long as the marriage lasted 9 months, you didn't remarry prior to the age of 60, you can actually draw benefits from the deceased spouse. But my point is this, we're always looking for 40 quarters to be eligible for Medicare A and B. Now, in order to have an Advantage plan, the way those work, eligibility is you have to be enrolled in Medicare A and B. So I'm eligible for A and B, and then I can choose to be covered by an Advantage plan. Now, the way drug plans work, eligibility, you have to be eligible for A or B, either one. It doesn't have to be both, but either one, and you have to be enrolled in one of those A or B systems, and then you can get a prescription drug plan. All right, so again, the 4 parts of Medicare, that's the eligibility, and then the enrollment issues are like this. Most people are going to go on Medicare at 65. And that means that they have paid in 40 quarters and now they're going to go on Medicare at 65. And that's what most are going to do. But I want you to know that not everyone has to go on Medicare at 65. And the group of people that don't have to do Medicare at 65 are those that they or their spouse are still working, covered by an employer-provided plan that has 20 or more people on the payroll. As long as we have 20 or more people on the payroll through that group plan, you don't have to go on Medicare. Your spouse does not have to go on Medicare. You're really exempt and actually can delay going on Medicare if there's 20 or more people on the payroll and you like the group plan. Now, those that are not working or their spouse isn't working, you have to go on Medicare at 65. So if you're covered by a retiree plan or an Affordable Care Act, ACA plan, or a COBRA plan, or a group of 19 or less on the payroll, then you have to go on Medicare. So some have to go on and some don't. So if you're in the category of those that have to go on Medicare, if you're already on Social Security, Medicare will automatically enroll you into Medicare A and B, and you'll get your Medicare card in the mail just a little over 3 months before your birth month. If you're not on Social Security, then you actually have to self-enroll into Medicare. So again, we're on a retiree plan, an Affordable Care Act plan, a COBRA plan, or a group of 19 or less, you're going to have to self-enroll. You'll do that process by setting up what's called a myssa.gov account, and then you can do a Medicare-only application, or you can do a Medicare application including a Social Security application all at the same time. Okay, so that's how we enroll. We have 40 quarters. If we're on Social Security, we're automatically enrolled. If we're not, then we're going to have to raise our hand to the government and say, I'm ready to start my Medicare benefits at 65. So that, again, is the enrollment process. Now, if you're going to start at 65, we call that the initial enrollment period. And it only lasts 7 months. And so you have to, if you have to self-enroll, you need to enroll during that 7-month period of time. And the month that you select to enroll will determine when they start your coverage. And so keep that in mind. That 7-month window is very important. It's 3 months before you turn 65, the month you turn 65, and then 3 months after. And so if we have to self-enroll because we're going on Medicare at 65, it has to happen during that 7-month period of time, and the month you select to enroll will determine when they start your benefits. Okay? Now, so that's the enrollment period. Now, again, the same thing would apply for Advantage plans. You've got to be enrolled in A and B in order to be eligible for the Advantage plan or for the prescription drug plan. All right, so that's enrollment, that's eligibility. Now let's talk about the coverage. How is your insurance going to work? You know, I tell people all the time, you really don't know how good your insurance is until you need it. Just a side story here, really, and what you know, this story ended up wonderfully, but it could have been very tragic. I have 7 children. I think that most of you know that by now that have watched this for a while. 5 of those were born into our family, and 2 were adopted from the country of Uganda. My youngest biological son, when he was 17 years old, had a gentleman on purpose pull out in front of him on a major highway, and they had a very serious car wreck. My son lived. The other gentleman did not. He actually was committing suicide. Very, very sad story. And he was successful that he perished in that wreck. And my son was not at fault. This guy meant to do what he did. You know, obviously sad situation that resulted, but my son lived. But I learned you never really know how good your insurance is until you need it. And I certainly needed it then. And I had a fairly decent policy, and it paid everything. Paid the family, paid for all the injuries and all those things. I saw my insurance work. And so you don't know how good it is until you see it work. And that's what I mean by what experience are you going to have whenever you begin to use your insurance. It really is critical to understand that. And this is why I'm not a real fan of all the ads that you'll see on TV, because they really don't tell you everything, what's going to happen as you need that insurance. So I'm going to talk about that a little bit here in just a minute, but let's talk about the expenses. What's involved in the expenses in Medicare? So again, Medicare A has zero premium. So when you enroll in Medicare A, there's zero premium as long as you have 40 quarters. Medicare B does have a premium. Now this year, and today is August 22nd, 2022, right now, the majority of people are paying $170.10 a month for their Medicare Part B premium. $170.10. Now, this is based upon income, which is called your modified adjusted gross income. And so it's your income that determines how much we pay for Medicare Part B. Now, if you're a single filer and you're below $91,000 a year in modified adjusted gross income, you'll pay $170.10 a month for your Medicare Part B. If you're a married couple, you file a joint return. As long as you're below $182,000 a year in modified adjusted gross income, then you'll pay $170.10 a month for Part B. Again, if you're on Social Security, they take that Part B premium out of your Social Security check, and if you're not, they're going to bill you for it on a quarterly basis until you start taking your Social Security checks. Once you're on Social Security, Part B has to be paid through our Social Security checks. All right, so we're going to pay zero for Part A. B has a premium. Now, if you're single and above the $91,000, you're going to pay extra. Those extras are called IRMAs. It's an acronym that stands for Income Related Monthly Adjusted Amount. If you're a married couple, $182,000 or above, each of you, again, would pay an IRMA, Income Related Monthly Adjusted Amount. Now, I don't have the time to go through this, but you could go to our website at medicareschool.com, and I teach about the IRMAs. But here's the point. People that are above those limits are going to pay more. And that ranges depending upon how high you are above that limit. So it's anywhere from about $80 a month IRMA up to about $500 a month in IRMA, because we have IRMAs on the B of Medicare as well as the drug plans. Okay, and so that is going to be part of the expense of Medicare A and B. A is free, B has a premium that will pay for Medicare. Now, beyond just the premium of Medicare B, there will be some out-of-pocket expenses if you decide to stay in original Medicare. We call those gaps in your coverage. And so the way to remember the gaps, to understand them, is to realize that there's 3 gaps on the A of Medicare and there's 3 gaps on the B of Medicare. The gaps on the A of Medicare are a hospital deductible. This year, that's $1,556. It's a deductible that can occur more than once in a year because it's not an annual deductible. It's called a benefit period deductible. So every time we're hospital and we start a new benefit period, we owe a deductible. It's very reasonable, $1,556. Gap number 1. Gap number 2 is if we're in the hospital more than 60 days, we get into daily copays. Month 3, month 4, and month 5 in the hospital carry daily copays. Again, they're very expensive, basically about $400 upwards to about $800 every day in the hospital if we have extended hospital stays. That's the second gap in Medicare A. And the third gap would be what we call skilled nursing copays. Now, the first 20 days in a skilled nursing facility, inpatient rehab, Medicare covers everything. After that 20 days, then Medicare begins to charge you daily copays. Right now, those are $194.50 a day. So as long as I've been in the hospital 3 days or more, the first 20 days, Medicare covers everything. After that, I have a daily copay, $194.50. And my point is this: those are the 3 gaps that are on Medicare A. Now, B also has 3 gaps. We start the calendar year off with a deductible. That's $233. That's the B deductible. And then we go into co-insurance, which is 20%. Remember, Medicare pays 80%, you pay 20%, and then there's a possibility of going to a doctor that adds to the bill. When the doctor adds the bill, that's called an excess charge. That's 15% added to the Medicare bill, and that's your third and final gap. And the whole point is this: if you make the choice to stay in original Medicare A and B, you have 6 gaps you're responsible for, 3 on the A and 3 on the B. And so what you can do is transfer the liability of those gaps to an insurance company so you don't have to pay for those gaps out of your pocket. And the top plans right now are the Plan F and the Plan G and the Plan N. And those are plans that you can actually transfer liability to an insurance company, and they will either cover all the gaps, such as the F, or some of the gaps, such as the G and the N. And so the whole point is, when we go in original Medicare, we have these gaps, and we don't want to be liable for them, so we will buy a supplemental plan, and we'll have a separate premium for that. And again, that's one of the expenses when you go on Medicare. If you choose to get a supplemental plan, you're going to have to pay a monthly premium for those plans, right? Now, if we take an Advantage plan, what's happening? We're getting a replacement reimbursement plan. Now, our expense with those would be we have to pay Medicare B because we have to be enrolled in A and B to have an Advantage plan. But instead of paying a premium to the insurance company, what we're going to do is we're going to pay as we go. We'll have a copay to go to the hospital, a copay to see a specialist, a copay to get an MRI or a CAT scan, a copay to have an outpatient procedure, an outpatient surgery. So with the Advantage plans, we pay as we go until we hit a certain max out of pocket for the year. Okay, so original A and B has gaps. Most people buy a supplemental plan and pay a premium to fill in the gaps. Others that want an Advantage plan, they just simply pay as they go until they hit the max out of pocket. And then drug plans. The way they work is we have a premium for them if it's a separate drug plan. Those are standalone drug plans. So if I stay in A and B and get a supplemental plan, I'll have a separate drug plan. In most zip codes, there's anywhere from 15 to 25 plans to choose from. And those Part D plans are one I'm going to give you the details here in just a minute about those changes that are coming forth after January 1, 2023. But separate drug plans have a premium. They're as low as $7 a month, upwards to probably $50, $60 a month. The average is about $30 a month for a drug plan. And so when you go on Medicare, you're making these decisions. How do I want my insurance to work? Do I want to stay in A and B with the supplemental plan to fill in the gaps, pay a premium for that supplemental plan, and they get a separate drug plan? Or do I want to replace that system with a private health insurance option called an Advantage plan, where all I have to do is pay Medicare B, no premium to the insurance company usually, but then I pay as I go until I hit the annual max out of pocket. So those are the two systems. All right, so those are the expenses that are going to be involved in those two systems. Now, I want to share with you, what will these coverages look like? In other words, if you need this insurance, what are you going to experience? So if you decide to stay in original Medicare A and B and you get a supplemental plan, the first thing that you're going to experience is you're going to pay premiums. And what you're doing is paying premiums to get rid of almost all the out-of-pocket expenses that are involved. People that have supplemental plans have no financial surprises whatsoever. They know exactly what the premium is going to be. They know what their out-of-pocket expenses are going to be. When people take an Advantage plan, that's when the surprises can occur, because you're now going to pay as you go. And you don't know what healthcare expenses are in store for you. Could be wonderful, could be terrible. But because it's a pay-as-you-go system, sometimes you can be surprised by large bills as you're in that pay-as-you-go system. But again, that's the difference between the systems, either premium-based coverage or copay-based coverage between those two systems. Another thing that you're going to see different would be the providers. And again, I'm talking about what are you going to experience when you choose your insurance? Well, if you take a supplemental plan, your providers are almost unlimited. And the reason for that is because any provider that takes Medicare, you can go to the provider, they will take your supplemental plan. So any hospital, any doctor, any specialist that takes Medicare will take your supplemental plan of choice. Whatever company you choose and whatever letter you choose for your supplemental plan, they will take those plans. So all you have to find out is, do you take Medicare? Now, when it comes to Advantage plans, it's different. Now we're going to have networks, either HMOs or PPO networks. So when you go to those providers, you have to find out, will they take your plan, or are they in the network? And some providers will take both HMOs and PPOs. Some will only take a PPO plan, and then some will take none of them. It's totally voluntary. But again, we're talking about your experience. So you have to decide, am I comfortable with maybe less providers to choose from? Do I want to be restricted to some of the network rules, meaning sometimes they require you to have a referral, maybe a pre-authorization whenever you're in those network plans. And so you have to decide that. And then thirdly, it does take us to the issue of pre-authorizations. If I decide to stay in A and B with a supplemental plan, you will never have a pre-authorization. If the Medicare says we'll cover it and the doctor says you need it, it's on the schedule and the service is completed. If you have an Advantage plan, about 70% of the services have to be pre-approved. So the doctor says we need to do a surgery, or we're going to do an MRI or a CAT scan, and then the insurance company has to agree with that, has to have a final approval. They have the final say-so on the plan. Not your doctor, and certainly not you, but the insurance company does. In fact, just last week, had someone call in that wanted to switch from their Advantage plan to supplemental plan because his wife needed a knee replacement, and the Advantage plan did not agree with that. Doctor says you need a knee replacement. The Advantage plan said, no, you don't. We don't believe that's necessary, and so they would not approve that. So again, it's a different experience. And so we have provider networks. Thirdly, we also have permanency. when you enrolled in A and B, it is for life. When you get a supplemental plan, it also can be for life. You certainly have to pay your premium, but that policy can never be canceled by the insurance company. Advantage plans are not permanent. They're 1 calendar year that can be switched on an annual basis if it's necessary for you to switch them. All right, so again, a difference in time period. And then portability. That means if you move from one state to another or one city to another, can you take your policy with you? A and B, yes. It stays with you for life. It's the same coverage anywhere in the country. And supplemental plans are the same way. They are portable. If you you live in Denver, you move to Dallas, take it with you. You live in Kansas City, move to San Francisco, take it with you. They're totally portable when it comes to supplemental plans. Not so with Advantage. Advantage plans are tied to a metro area, a service area. If you move out of the service area to a new service area, simply right now I'm from the Kansas City metro area. You move from Kansas City to St. Louis. You're in the same state, but you moved a service area. You have to get a new plan whenever you move. And so that's the way the Advantage plans are going to work. So again, we're talking about portability. And then when it comes to perks, and this is a big deal because of all the ads, I will tell you that supplemental plans have very few, if any, perks. It is just pure insurance. Advantage plans have perks. They'll throw in some dental benefit, maybe a vision benefit, hearing aids. They may throw in an over-the-counter card, sometimes reduce your Part B, but the Advantage plans are the ones that have all these perks. Supplemental plans do not, and so you have to decide, again, what are you looking for with your insurance coverage? And so that's a decision you're going to have to make. And then lastly, and this is a big deal when it comes to switching plans. If you start off with a Medicare supplemental plan, there's no underwriting required whatsoever. Those insurance companies have to take you. But after 6 months of being on a supplemental plan and you want to move to a different one, in most states you have to medically qualify to do that. If you have an Advantage plan, you want to switch over to a supplemental plan. After 1 year, you're going to have to medically qualify to do that. And so we remind people, you have to know the rules for switching your plans, because there are sometimes people take an Advantage plan, they've been on 2, 3, 4, 5 years, and they want to get off and move to an Advantage plan, to a supplemental plan, and now they're in a state where they have to go through medical underwriting, which is most of the states. And so if their health has changed, they may not be able to make that switch. And so always know, what are the rules for switching my plan, because it's very, very important. So many people think because Medicare has this open enrollment period, they can just switch and move around very freely, do what they want. And folks, it doesn't work that way. There's always going to be rules for switching. All right. And so all I was trying to share with you as we look at Medicare, the inpatient and outpatient side of Medicare, what is it going to look like? Okay, because you have two options, and those options are vastly different. So you got to decide what is best for your situation. All right, so let's wrap this up, and now let's talk about drug plans. Okay, now drug plans, remember, if I have a supplemental plan, it's a separate drug plan. If I have an Advantage plan, it's almost always embedded within the drug plan. And so the way it's going to work in both of those systems is, number one, you're going to have a formulary of drugs. It's a list of medications that are covered by the plan. And folks, it's the most important part of your drug plan decision is the formulary. Will my medications be covered? You want to make sure that you pick a plan that your meds are going to be covered. Secondly, you're going to have some pharmacies. And in that network of pharmacies, there's going to be a couple of pharmacies that will be preferred pharmacies, which means better pricing, and then the rest are going to be standard pricing. Now, frankly, when it comes to generic medications, rarely is there a big difference. But when it comes to brand name meds, there are times when there's a big difference. And so one plan may have CVS as a preferred pharmacy, another one has Walmart and Walgreens, another one may have maybe a local grocery store that's preferred pharmacy. But be sure that you look at preferred pharmacies, because you want to get your prescriptions from a plan where your pharmacy is preferred within the network, because it can save you substantial money. All right, and so every plan is going to have a network of pharmacies. Every plan is going to have a formulary of medications. Plus, every plan is going to take all the medications they cover, and they're going to give them a tiering number. Tier 1, 2, 3, 4, 5, and that tiering number just simply establishes your out-of-pocket copay. All right. And then fourthly, you need to know that there are some medications when you look at the formulary, they have what's called a step therapy. And that means that this medication that you want to take has step therapy, which means there's generic equivalent or alternatives to that medication that are cheaper, and that plan is going to say you must try the lower cost meds, and then if that doesn't work for you, then they can step you up and eventually get the brand name. But you have to live with those rules on Medicare plans. And then there's some that are called prior authorization meds, and these are very expensive medications. And before the plan will actually allow you to get that prescription filled, the doctor has to fill out certain paperwork saying this is why we need this medication. And so if you have a prior authorization or a step therapy, you just simply have to live with the rules. And so whether I have a drug plan that is standalone or it's embedded within the Advantage, I'm still going to have all these rules. We're going to have a formulary, we're going to have a standard and preferred pharmacies, we're going to have tiers, prior authorizations, as well as step therapy. All right, and then the last part of drug plans is the most confusing part. And by the way, this is going to change with the recent legislation. But as it sits today, what's happening is this. Every drug plan has 4 stages. And that just simply means that depending upon the stage that you're in, as the stages change throughout the year, your copayment can change. In 1 year, you could be on a medication that actually changed copays 4 times. Why? Because depending upon the stage that you're in will determine what your copay is going to be. So there's 4 stages. Some people call these phases. Every plan has the same order. Stage number 1 is the deductible stage, which means if you have to meet a deductible, it just simply means your copays are applied to the deductible. If we meet our deductible, most don't, but if you do, you'll go to stage 2. And stage 2 is called the initial coverage stage. And that's very reasonable copays that you'll pay out of pocket. But while we're getting prescriptions filled in stage 1 and stage 2, you're paying your copays, but Medicare's tracking the retail cost of your medications. And if that retail cost total sometime in the year ever reaches a certain number called the threshold, the Medicare threshold for drug plans this year is $4,430 retail. That is not your cost at all. You may have spent $1,000 of that $4,000, but Medicare tracks retail. And if we ever get to that threshold, $4,430, we leave stage 2, we go to stage 3, which is called the donut hole. And in the donut hole, usually our copays go up because there we have a flat 25% copay of any medication while we're in the donut hole. So if I have a $100 medication in the donut hole, retail $100, I pay $25. If the medication $500 retail, I pay $125. So we have a flat copay in stage 3 called the donut hole of 25%. And then they're tracking a whole nother number. This is called the true out-of-pocket cost. Very confusing, but the point is this year it's $7,050. It's not what you spent, it's actually what you spent and the manufacturer discount, as well as what the insurance company spent. But that total amount, if it reaches $7,030, we're done in stage 3 and we go to stage 4, which is called the catastrophic stage. And in the catastrophic stage this year, you pay 5% of the retail cost. All right? So 4 stages, 4 different copays, and we move throughout the year so our copays can go up and they can go down. And the way to get your mind around this as a comparison is to remember your drug plans at work or your drug plans that you had as an individual. You didn't have 4 stages. You had 1 stage. You had a fixed copay all year long. And so whether you got the prescription in January, July, or December, you paid the same copay all year long. When you go on a drug plan with Medicare, we have 4 stages, so our copayments can adjust throughout the year, 4 different stages. Okay? And so all drug plans have those. You cannot avoid those, but that will be a change I'm going to share with you in the future when it comes to drug plans. Okay, so we have a separate drug plan, or we have one that's embedded within the Advantage for our prescription drug coverage. All right, and so very important to understand what we have going on with these plans. All right, so the good news is about drug plans as well as Advantage plans, we can change them on an annual basis. And folks, that's the purpose of this upcoming open enrollment season. We call this the AEP, the annual enrollment period. And this is a time when people can change without any underwriting. They can get off their Advantage plan and go to a new Advantage plan. Or they can get off their drug plan and go to a new drug plan. As long as that plan is available in your zip code, you can make that switch without any underwriting. And so we'll be soon approaching that, October 15th to December 7th. And the most important thing to remember is that October 1st or so, the insurance company that has you covered with your Advantage plan or your drug plan is going to mail you a packet. It's kind of a thick packet, and it's called the Annual Notice of Change. And my most important piece of advice to you is open that packet and see what the plan is going to change. Find out what's the new premium for 2023. What's the network look like? What's going to be covered? What kind of changes are they going to make? If you still like the plan after you review the changes, do nothing. Your plan will automatically renew. But if you don't like the changes and maybe the plan has dropped a medication or they're really changed their premium or your doctor's left the network or something's going on that is not in your best interest, then you can switch the plans between October 15th and December 7th. And again, there's no underwriting. The plan you're on now takes you to December 31st, but that plan that you switch to will go into effect on January 1 because again, it'll be a calendar year plan. All right, and so that's what's going to happen with drug plans and Advantage plans. All right, now let's talk about those all-important changes that came about with the Inflation Reduction Act. Okay, now there's 3 changes that are going to be implemented January 1 of this year. And then again, there'll be some others that are going to come over the next 4 years. But January 1, 2023, the biggest change we're going to see is this. If you are on insulin, an insulin drug that is actually going to be covered by the Medicare plan, the maximum copay will be $35 a month. Right now, there's some insulins that are already on that plan. There's others that are much higher than that. But any medication, any insulin, that will be covered by Medicare, and in a prescription drug plan's formulary, the most you'll pay out of pocket is $35. Now, the thing to note here is this. Not all insulins are going to be covered by Medicare, okay? Not going to be covered by all the formularies, and that's why you got to shop and look and compare to make sure that if your medication is going to be in that Medicare plan, you're choosing one that will be at the $35 copay, because not all of them are going to be in there. But if they are, max to you will be $35 a month. And then this year, they're going to have an inflationary control that's going to be built within. Up to this point in time, as it is today, drug plans can just change their Part D premiums randomly. They can just raise them. In fact, last year we had one that tripled their price. We had one that doubled their price. But moving into 2023, that cannot happen. The most a drug plan can raise the premium, that means they're at $7. The most they can raise that up is whatever the general inflation is for the year, which has been about 8 to 10%. So they cannot raise it up drastically like they've been able to in the past. So January 1, 2023, your drug plan cannot go up any more than general inflation. That's one of the pieces of legislation that were in the Inflation Reduction Act. Okay, the number 3 for this year would be what's called adult vaccinations, adult vaccines. Now, presently, this year, 2022, we actually have 4 vaccinations that are covered by Medicare at zero cost share, meaning nothing out of your pocket. And that would be the flu shot, pneumonia shot, hepatitis B, and COVID vaccinations and boosters. Those are zero cost sharing, totally free to you. Beginning in January 2023, they're going to add all qualified adult vaccinations. And really the big one for that would be the shingle shot. Up to this point in time, Medicare has covered shingle shots, but there was cost sharing on your part, sometimes a deductible, sometimes a copay. But that is going away next year, so the shingles vaccination will be zero out of pocket, or any other adult vaccination, something that maybe you didn't have as a child that you now need, then that, if it's in the list of covered vaccinations, there will be zero out of pocket for that. So that's the 3 changes going on for 2023, insulin, inflation control, and then adult vaccinations. Then starting in 2024, what is going to happen, remember I just educated you about the confusing 4 stages. Remember, we had deductible, initial coverage, coverage gap, donut hole, and then catastrophic. Now, if you're in the catastrophic stage this year, as I told you earlier, you have a 5% out-of-pocket expense. Very reasonable, very cheap. But beginning in 2024, that 5% cost share on your part, that co-insurance, is going to zero. So if anyone does get to the catastrophic stage in 24 and beyond, they will have a zero out-of-pocket in that stage. They'll still have their out-of-pockets in stage 1, 2, and 3, but 0 in stage 4. So that's a change that will be enacted in January of 2024. Then another inflationary increase, cost control device, will be when it comes to drug plans. Now keep in mind, folks, remember, there's 15 to 25 drug plans in every zip code. And these drug plans up to this point in time could set the premiums anything they wanted to. Going into 2023, they can not go up any more than inflation. Beginning in 2024, forever, until there's new legislation, the most they can raise a drug premium would be 6%. So if I'm on a drug plan that costs $10, they can raise it 60 cents in premium. So very, very limited. So these drug plans are really going to have their hands tied now as far as being able to raise the premiums. They'll be limited to a 6% on an annual basis, which frankly is not very much. All right, now in 2025 and beyond, here's the biggest change that came from the Inflation Reduction Act, and that's this. Remember how I told you that we have these stages and you're out of pocket, a deductible, you have co-pays, you get the donor hole, you have all these out-of-pocket expenses. From January 1, 2025 moving forward, the most anyone will spend out of pocket on their prescription drugs will be $2,000. I don't care if the medication is $10,000, $20,000, makes no difference. Your out-of-pocket cost will be capped at $2,000 a year beginning in January of 2025. So that's wonderful news for those of you that are on real expensive medications. Folks, I have clients right now that are on medications that are $7,000 a month, self-administered chemotherapy pills. Had a guy recently that's on a medication $16,000 a month. Now, he didn't pay the full price, but he is paying $800 a month. And so anyone that's going to be on these expensive medications now, be they heart meds or insulin or all these kinds of things, $2,000 max out of pocket beginning in January 2025. And then in 2026, what's going to happen? This is kind of one that I think is a little bit bizarre, honestly. I think they should have started this much, much earlier, but it's going to start in 2026. Medicare will now be empowered to negotiate prices with the manufacturer of the medications, those that are expensive. They'll be able to negotiate those prices. And in 2026, they're going to select 10 medications. In 2027, they're going to select 15. In 2028 and thereafter, they're going to select 20 more medications each year, and they'll start including that, and they'll begin to negotiate those prices to get those out-of-pocket expenses down. Now, I don't know why they didn't do that this year. I think they should, but for whatever reason, that didn't start until 2026. But it will be good at that particular time. And we're talking about, MS medications, diabetes medications, chemotherapy, these different things that are very, very expensive. The government, through Medicare, is now going to be able to negotiate those. Now, what's interesting to me, being in the business, is that Medicaid can do it now. The VA can do it now. And that's why their medications cost 32% more, because years ago, the government empowered them to negotiate those prices. And again, once we get to 2026, Medicare will now be able to do the very same thing. All right, now a couple items that are not so good of news. Number one, the dental vision hearing discussion of including those things in original Medicare. Those things are still up for negotiation. That was not part of this legislation. Now, again, keep in mind, if you get an Advantage plan, you will have some additional dental vision hearing benefits that they throw in. But original Medicare still has not decided about coverage in those areas. And then, and this is kind of interesting, but they say that in 2028, the Hospital Part A insurance fund is going to be at a place where now they'll only be able to cover about 90% of those expenses. So just like we have this timetable for Social Security, I think right now they're saying, by 2032, they'll only be able to pay, I think it's 80% of every dollar due. In 2028, on the hospital side of Medicare, they'll pay 90% of every dollar, unless, of course, the government makes some adjustments, which I anticipate they will do so. All right? And then the real good news, and this is just overall, when we look at this Inflation Reduction Act, folks, there's nothing that's going to hurt you as the Medicare beneficiary. And again, I'm not saying you align with everything they're doing politically. That's not the issue. The issue is there's nothing that you as a Medicare beneficiary is really going to be hurt by this legislation. Again, it had mostly an impact on drug plans, and again, all those situations are going to improve. And then lastly, some people qualify to get what's called extra help. Extra help means that a person qualifying for extra help can get extra help paying for their B premiums, their drug premiums, their co-pays for their prescription medications. And so right now it's very limited eligibility because the income and the assets are such a low threshold. And so what's going to happen next year, they're going to start raising those thresholds so more people will be eligible for the extra help program. And again, you can apply for that through the Social Security office. You can go online and do that, but they are going to raise the threshold for income as well as the threshold for assets so more people can get help with their prescription drug plans. Okay, now, folks, I know I covered a lot, but I do hope that was helpful. And keep in mind, if you want some additional education, I would encourage you to go to our website, MedicareSchool.com. And I have lots of videos there, a workshop called the Essentials Workshop, and I really get into the details. And so take the time to get educated. You're going to be on Medicare 25, 30 years on average, and so you want to make good decisions. So that's the purpose, really, of those workshops, for you to really understand what you're doing before you make any decisions. And you may be in a position where you say, hey, I understand, I'm ready to take action. If you would like to use someone like us, we are independent brokers, so we write for almost all the carriers that you would be considering. We can lay each of those plans, options out side by side, compare premiums, compare stability, and we're happy to do that. We call our agents Medicare Guides because that's their goal, and that is to guide you through the process, to take the time necessary to be patient and look at your situation to see exactly what is going to be the best coverage options for you. And all the services we provide for you are totally free to you because the insurance company, of course, always pays the agent. You're not responsible to do that, so it's really nice. Our services truly are free to you. We don't work for free, but the insurance companies will pay us. And keep this last in mind, whatever you would like us to do, whether that would be to enroll you into Medicare A and B, help you set up your Social Security, enroll into what's called an SSA.gov account, whatever paperwork's necessary for you to get enrolled into Medicare and the Social Security, we can walk you through the whole process. And you'll not save any money doing it yourself. You could cost yourself a tremendous amount if you do not do it right, okay? And again, I see so many people who make mistakes because of a bad advice or an agent who really didn't know what they were doing, and we don't want that to happen to you. So reach out to us, and you can make an appointment on our website, MedicareSchool.com, with a guide who will be patient with you, answer your questions, and give you a thorough comparison of all of your options. It'd be our privilege to help you. So reach out to us, and if you have any comments or if you have a topic I didn't cover, put it in the comments section there. And by the way, Tara Yancik is the one who oversees this site. Tara is very, very knowledgeable, very sweet, very helpful, and she's a real servant, so she'll do whatever she can to answer questions. And if you want me to cover something, please put a comment section there, and I'll try to tackle that on a Medicare Monday in the future. Again, thanks so much for watching. Tell your friends about Medicare Monday. And then real soon, you can probably see in the back there, we have Retirement Real Talk. My son and I, Joshua, have started a podcast, and we'll tell you more about that, but that's getting ready to air as well. And every week we'll tackle topics about retirement, Social Security, Medicare, as well as the investment side as well. So reach out to us if we can help you. Thanks so much for watching. Have a great week.